Hello everyone. Welcome to this step-by-step operative guide on laparoscopic complete rectal mobilization. In this video, I will demonstrate my systematic approach to laparoscopic rectal mobilization. The first step is establishing an adequate working space within the abdomen. The omentum is reflected cranially, while the small bowel is gently displaced towards the right upper quadrant. This provides unobstructed visualization of the left colon, sigmoid mesocolon, and pelvis. Traction is now applied to the sigmoid mesocolon. This maneuver places the peritoneum under gentle tension and clearly defines the line of incision. The peritoneum is scored just to the right of the sigmoid mesocolon, allowing entry into the correct embryological plane between the mesocolon and the retroperitoneum. Once the proper plane has been entered, the dissection proceeds smoothly with minimal bleeding. The mesocolon is carefully elevated away from the retroperitoneum while maintaining constant traction and countertraction. During this step, particular attention is paid to identifying and preserving two important retroperitoneal structures: the left ureter and the gonadal vessels. Early identification of these structures is critical in preventing inadvertent injury during further mobilization. The dissection is continued in a medial to lateral direction until the lateral abdominal wall is reached. Maintaining the correct embryological plane not only protects the retroperitoneal structures, but also greatly simplifies the subsequent stages of mobilization. Whenever operating in a previously operated pelvis, patience is essential. Excessive traction should be avoided, and dissection should always proceed under direct vision while respecting tissue planes. The objective is to restore normal anatomy before beginning definitive rectal mobilization. The dissection now extends beyond the sigmoid mesocolon onto the proximal rectum, maintaining the same avascular embryological plane between the mesorectum and the retroperitoneum. Gentle cephalad traction on the rectosigmoid junction helps place the tissues under tension and clearly defines the dissection plane. The mesorectum is carefully elevated while remaining immediately outside the mesorectal fascia, allowing safe progression into the upper pelvis with minimal bleeding. Developing this posterior plane early provides excellent orientation for the subsequent stages of rectal mobilization and facilitates identification of the correct pelvic dissection plane. The lateral peritoneal attachments of the sigmoid colon are then divided. This completes mobilization of the sigmoid colon and upper rectum, allowing the rectum to be elevated and placed under appropriate traction. Adequate mobilization of the sigmoid colon before entering the pelvis greatly improves visualization during the subsequent pelvic dissection and facilitates safe circumferential mobilization. With the sigmoid colon and upper rectum adequately mobilized, attention is now directed towards complete rectal mobilization. A useful way to understand pelvic dissection is to think of the rectum as having four distinct sides: anterior, posterior, right lateral, and left lateral. Successful rectal mobilization requires systematic development of each of these planes while maintaining an intact mesorectal envelope and respecting the surrounding pelvic anatomy. The anterior plane differs between males and females. In female patients, the objective is to develop the plane between the mesorectum posteriorly and the posterior vaginal wall anteriorly. In male patients, the anterior dissection is carried out between the rectum posteriorly and the prostate and seminal vesicles anteriorly, usually after dividing the rectovesical peritoneal reflection. The posterior plane is developed within Heald's holy plane, between the mesorectal fascia anteriorly and the presacral fascia posteriorly. His is an avascular embryological plane that allows safe mobilization with minimal bleeding while preserving the integrity of the mesorectal envelope. Particular care should be taken to avoid breaching the presacral fascia, as this may result in troublesome presacral venous bleeding. The right and left lateral planes are then developed by separating the mesorectal fascia from the endopelvic fascia. As the dissection progresses, distally, the lateral rectal stalks are encountered and are divided using an energy device while maintaining the correct fascial plane. Throughout the procedure, the dissection is carried out circumferentially, progressively connecting the anterior, posterior, and lateral planes. Continuous traction and counter-traction facilitate identification of the embryological tissue planes and help maintain excellent visualization throughout the pelvic dissection. One useful concept during pelvic surgery is to think of the rectum as a cylindrical structure that must be progressively freed on all four sides while maintaining an intact mesorectal envelope. Approaching the dissection systematically in this manner provides excellent orientation, minimizes unnecessary tissue handling, and allows the surgeon to remain consistently within the correct embryological planes. The circumferential rectal mobilization is continued distally. The mesorectal fascia remains intact throughout the dissection, reflecting the principles of total mesorectal excision, gentle traction, meticulous tissue handling, and careful energy application allow progressive descent towards the pelvic floor without unnecessary bleeding or injury to adjacent structures. At every stage, it is important to reassess orientation before proceeding further. Remaining within the correct fascial plane is considerably easier than attempting to recover after entering an incorrect plane. This disciplined approach not only facilitates the operation, but also contributes to improved oncological outcomes by preserving the integrity of the mesorectal specimen. Finally, meticulous technique, careful tissue handling, and strict adherence to oncological principles are essential for achieving a safe operation and an optimal surgical specimen. The endpoint of complete rectal mobilization is characterized by several important anatomical landmarks. The mesorectum can be seen tapering progressively as it approaches the pelvic diaphragm. Most importantly, the levator ani muscles become clearly visible circumferentially. Visualization of these muscles confirms that the dissection has reached the pelvic floor and that complete mobilization has been achieved. At this stage, the rectum is fully mobilized and ready for the perineal phase of an abdominoperineal resection, or for distal rectal transection during sphincter-preserving surgery, depending on the planned procedure. My take-home messages would be: complete rectal mobilization is built upon a detailed understanding of pelvic anatomy and embryological fascial planes. Maintain excellent exposure before beginning pelvic dissection. Think of the rectum as having 4 distinct planes: posterior, anterior, right, and left, and mobilize each plane systematically. Remain immediately outside the mesorectal fascia while preserving adjacent pelvic structures and autonomic nerves. Thank you for watching. If you found this video useful, please consider subscribing to the channel for more operative masterclasses in gastrointestinal and hepatopancreatobiliary surgery.